Imagine a patient surviving a masterclass, 4-hour robotic bowel resection.
Right.
They beat a 1 in 100 odds of an anastomotic leak in a completely contaminated field. The surgical technique was flawless. The source control was absolute.
The total win.
Exactly. They get discharged on postoperative day 5, seemingly a total triumph of modern, minimally invasive surgery,
Yeah.
only for their zip code to kill them 2 weeks later. Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
I love that framing because it really captures the tension we're looking at today.
It really does, and I am thrilled to launch into today's material with you. And when I say you, I mean the peer listening right now.
Exactly.
The surgical resident navigating the brutal realities of your chief year, the seasoned attending managing a chaotic trauma bay, the acute care surgeon operating in the United States healthcare system.
We see you.
We do. Welcome to this deep dive into the rapidly evolving and honestly often contradictory landscape of emergency general surgery.
It's a huge paradigm shift right now.
It is. We are looking at a paradigm shift in how we approach the acute abdomen, and we're doing it through the lens of 2 massive, highly disruptive publications.
2 very different ends of the spectrum, too.
Right. First, we're tearing into the mechanical and technical frontier of the operating room. We're examining the safety, the logistical feasibility, and the hard clinical outcomes of deploying robotic surgery for emergent diverticulitis.
Which is wild to even think about doing it 2 in the morning.
Seriously.
Yeah.
This data comes straight from a 2023 study by Kerfman and colleagues in the International Journal of Colorectal Disease.
Great paper.
But we aren't stopping at the sterile field. We're going to pivot sharply from intraoperative technique to the messy, unforgiving realities outside the hospital walls.
The sociobiological environment.
Yes, specifically the lethal interaction between geriatric vulnerability and neighborhood deprivation, and how that combination exponentially multiplies emergency general surgery mortality.
The numbers on that are staggering.
They really are. And that data comes from a 2024 paper by Zog and colleagues in the Journal of Trauma and Acute Care Surgery.
It is a brilliant pairing of sources because it forces us to reconcile the 2 extremes of our profession.
Right.
We have this tendency in surgical critical care to hyper-focus on what is immediately in front of us.
The tissue planes.
Exactly. The tissue planes, the staple lines, the vasopressor requirements. But the reality that the data is finally catching up to is that surgical success is the collision of advanced, hyper-precise operative technology with profound systemic patient vulnerability.
It's both. You can't ignore either.
You really can't.
Huh.
As a modern U.S.-trained acute care surgeon, your ability to risk stratify accurately and operate effectively, well, it demands a highly nuanced understanding of both the microenvironment of the peritoneal cavity and the macroenvironment of the patient's neighborhood.
So you need to know the specific tissue mechanics that justified deploying a Da Vinci Xi system at midnight.
Yes.
And you simultaneously need to understand how the specific census block your patient goes home to is actively altering their cellular capacity to heal.
Precisely. That is the exact tension we need to explore today.
So let's start inside the operating room, the technical frontier. Emergent acute diverticulitis.
Let's do it.
The dogma for this, the textbook approach battered into every one of us during residency has always been the open Hartmann's procedure.
Oh, absolutely.
We don't need to rehash the steps. Everyone listening has done 100 of them. You make a massive midline laparotomy. You resect the diseased perforated sigmoid. You bring up an end-descending colostomy, drop the rectal stump, and you get out.
The definition of damage control.
Exactly. It's rapid, it's definitive, and it gets a critically ill septic patient off the table before they enter the lethal triad.
Right, because time is tissue.
Exactly. Now, minimally invasive surgery has completely monopolized the elective colorectal space. Nobody wants to open for an elective resection anymore.
No, never.
But emergent cases, they have severely lagged. Laparoscopy has been tried, but navigating a hostile, fibrinous, inflamed abdomen with straight sticks is treacherous.
Treacherous is the right word.
But now robotic surgery is entering the fray. Not just for the cooled-off elective cases, but for the hot, acute emergencies. Give us the landscape. What exactly did the Kerfman study capture?
So the Kerfman et al. Study is this monumental retrospective review, and its power comes entirely from the sheer volume of its data source.
Where'd they get?
They utilized a custom hospital analytics database derived directly from Intuitive Surgical's national database.
Oh, wow. So direct from the source.
Yeah, we're looking at de-identified data spanning a crucial 3-year period, from January 2018 through December 2021.
Okay.
And the geographical and institutional spread is enormous. We're talking 262 separate surgical facilities and 1,130 individual surgeons operating across the United States.
That's a massive footprint.
It is. Initially, they cast a wide net, identifying over 22,000 emergent colorectal surgeries. But then they ruthlessly narrowed their focus to isolate a very specific clinical scenario.
What was the final group?
The final cohort, the N we are analyzing today, consists of 2,524 patients who presented to the emergency department with acute diverticulitis and who proceeded to have a sigmoid colectomy within 24 hours of arrival.
Okay, I want to pause on that 24-hour metric because it is the crucial differentiator here.
Absolutely.
These are true, undeniable emergencies. We aren't talking about the smoldering diverticulitis patient who gets admitted, cooled off with IV Zosyn for 4 days, fails to improve, and then undergoes a semi-elective planned resection on a Wednesday morning.
Right.
Operating within 24 hours of hitting the ED doors means these are the hot, highly inflamed, potentially perforated abdomens. The tissues are edematous, the planes are obliterated, and the physiologic stress is peaking.
Exactly. The acuity here is incredibly high. These are the cases where the surgeon is making real-time, high-stakes decisions about source control.
So how did the approaches break down?
Let's look at the breakdown for those 2,524 highly acute patients. Open surgery, adhering to that historical dogma you mentioned, took the absolute lion's share.
It's not surprising.
Now, 1,952 cases, which is 77% of the total cohort, were performed via an open laparotomy.
Okay.
Laparoscopy accounted for 446 cases, sitting at 18%. And then we have robotic surgery, a mere 126 cases, just 5%.
Hold on, I have to push back on that 5% figure right out of the gate.
I figured you might.
I mean, if only 126 out of over 2,500 emergent diverticulitis cases are being done robotically across 262 facilities nationwide, we are not looking at the standard of care.
No, we are not.
We are looking at the absolute bleeding-edge vanguard. Are these just the extreme robotic evangelists, like the surgeons who refuse to do an open case no matter what time it is or how sick the patient is?
It's a fair question.
Because how can we possibly generalize a 5% sample size to the reality of the average U.S. trauma bay?
Your skepticism is entirely justified, and honestly, it is the first major methodological caveat we have to anchor this entire discussion around.
Right.
A 5% adoption rate means this is definitively not the standard of care. You are absolutely right. These are highly likely to be surgeons who are extremely facile, high-volume operators with the robotic platform in their daytime elective practices.
They live on the console.
They do. And they feel a supreme level of comfort translating those advanced skills to an emergent, contaminated field at 2 in the morning.
Okay, fair.
However, even as a vanguard group, the data they generated is incredibly compelling. It provides a highly reliable window into what the future standard of care might look like as the technology, the training, and the institutional comfort levels disseminate over the next decade.
That makes sense.
Because when we look at the hard numbers, the statistical significance of their outcomes is impossible to ignore, even with the small n.
All right, let's get into those hard numbers. Translate the statistics into clinical impact for us. What actually happened to these patients?
Let's start with a metric that dictates hospital flow and resource utilization, which is ICU admissions.
It's a huge issue right now.
Massive. The robotic surgery group had exactly half the rate of ICU admissions compared to the open surgery group.
Half.
Exactly half. We were talking about 9.5% for the robotic cohort versus 19.0% for the open cohort.
Wow.
And that carries a highly significant p-value of 0.01.
That's robust. What about compared to standard laparoscopy?
When they compared the robotic group to the laparoscopic group, the robotic group was still lower, 9% versus 11%. But that difference wasn't statistically significant, carrying a p-value of 0.5.
Okay, but cutting ICU admissions from 19% down to 9.5% against the open group is massive.
It's game-changing.
It really is. That isn't just a win on a spreadsheet. That is physical ICU beds freed up for incoming traumas, fewer days on pressors, a drastic reduction in hospital-acquired pneumonias, and, of course, a massive reduction in overall cost. But we need to explain how it is achieving that. Why does the approach dictate the critical care needs so heavily?
Well, what's your take?
To me, it comes down to the inflammatory cascade. A massive midline laparotomy incision from the xiphoid to the pubis causes profound fluid shifts.
Right.
You have massive insensible losses just from the viscera being exposed to ambient room air for 2 hours. You are inducing a massive systemic inflammatory response on top of the pre-existing sepsis from the perforated diverticulum.
You are hitting on the exact physiological rationale.
Yeah.
Yeah, the open surgical approach fundamentally and violently alters the body's hemodynamics. You have extensive tissue trauma from the abdominal wall incision and the sheer force required by self-retaining retractor systems.
Which are brutal on the fascia.
Brutal. This mechanical trauma spikes massive cytokine release, specifically interleukin-6 and tumor necrosis factor alpha.
Oh, right, the classic cytokine storm triggers.
Exactly. This dramatically exacerbates the patient's baseline systemic inflammatory response syndrome. It drives vasodilation, it drives capillary leak, and it frequently necessitates post-operative vasopressor support and intensive hemodynamic monitoring.
Hence the 19% ICU admission rate.
Precisely.
Right.
By maintaining a closed abdomen, utilizing pneumoperitoneum, and limiting the incisions to a few 8mm port sites, the robotic approach severely blunts that secondary surgical stress response.
You are achieving source control without adding a massive iatrogenic physiological insult.
Exactly. But while the ICU data is impressive, the most staggering data point in this entire paper is the anastomotic leak rate.
Oh man, anastomotic leak. For anyone operating in the colorectal space, an anastomotic leak in an emergent contaminated field is the absolute nightmare scenario.
It's what keeps us up at night.
It really is. You construct what you believe is a beautiful primary anastomosis, you close the fascia, and 3 days later the patient is tachycardic, their temperature is 39 degrees, their white count is climbing to 25, and their abdomen is rigid.
The sinking feeling in your stomach.
Yes, it means a mandatory return to the operating room, a massive washout of gross enteric contents, a takedown of the anastomosis you just built, and the creation of a permanent or long-term stoma in a now critically unstable patient.
It is a catastrophic morbidity.
So what did the Curveman study actually find regarding leaks?
The drop in leak rates was nothing short of massive.
Give me the numbers.
The robotic surgery group achieved an anastomotic leak rate of a mere 0.8%.
What's under 1%?
Under 1%. Contrast that with the open surgery group, which suffered a 4.4% leak rate, carrying a p-value of 0.04.
That is a huge reduction.
And crucially, the robot didn't just beat the open approach. It significantly outperformed standard laparoscopy, too.
Really?
Yeah, the laparoscopic group had a 4.5% leak rate, again with a p-value of 0.04 compared to the robotic cohort.
That is phenomenal. 0.8% in an emergent, acute diverticulitis setting. But again, we have to demand the mechanism. Why is the robot achieving a 0.8% leak rate while standard laparoscopy, which is also minimally invasive, also avoids the giant midline incision, also maintains pneumoperitoneum, is sitting up at 4.5%? I mean, they are both utilizing port sites and cameras.
This is where we have to look closely at the intersection of mechanical advantage and tissue biology.
Okay, walk us through it.
The foundational principle of colorectal surgery is that a secure anastomosis requires two things. First, it must be entirely tension-free.
Right.
And second, it must be perfectly perfused. In an emergent diverticulitis case, the host tissues are notoriously hostile. The mesentery is foreshortened, thickened, and edematous.
It's like sewing wet tissue paper.
Exactly. The bowel wall is friable. Now, standard laparoscopy relies on straight, rigid instruments operating on a fixed fulcrum at the abdominal wall. You are essentially operating with highly sophisticated chopsticks.
That's a great way to put it.
It can be incredibly difficult and sometimes biomechanically impossible to get the precise angle required to pass a circular stapler or to sew a secure, hand-sewn anastomosis deep in the narrow male pelvis when the tissue is inflamed and unyielding.
Right, the rigid sticks create torque, and you lose tactile feedback when you are fighting the abdominal wall just to get the instrument tip where you need it.
Precisely. The robotic platform, particularly advanced iterations like the Da Vinci Xi, fundamentally changes that biomechanical equation.
Because of the wrists.
Exactly. The instruments feature articulating wrists that provide 7 degrees of freedom, mimicking the human hand but at a micro scale. The system entirely eliminates physiological surgeon tremor.
Which is huge when you're exhausted at 3 a.m.
Huge. It provides 3D high-definition stereoscopic vision, allowing for depth perception that 2D laparoscopy lacks. But perhaps the most critical technological advantage for preventing leaks is the seamless integration of indocyanine green, or ICG, fluorescence imaging.
ICG is a massive game changer. Let's explain exactly how that works for the listener who might not use it daily in their practice.
Sure. ICG is a fluorescent dye administered intravenously by anesthesia just before you are ready to construct the anastomosis. It rapidly binds to plasma proteins.
Okay.
The surgeon, sitting at the robotic console, simply taps a foot pedal to activate the firefly mode. The robotic camera switches to emit a specific near-infrared wavelength that causes the ICG in the bloodstream to fluoresce bright green.
It looks like magic the first time you see it.
It really does. Within seconds, you can visually confirm the microvascular perfusion of the colonic stumps in real time. You can literally see the exact demarcation line where the blood supply becomes inadequate.
So if it doesn't glow, you don't sew.
Exactly. If the tissue you plan to staple doesn't glow brilliantly green, you immediately know it is ischemic, and you resect further proximally until you find healthy, vibrantly perfused tissue.
And you just can't do that with the naked eye.
You simply cannot assess microperfusion with that level of objective certainty using the naked eye in an open case. And while ICG is available in laparoscopy, integrating it while wrestling with rigid instruments in a hostile pelvis is vastly more cumbersome.
Makes total sense.
The robotic precision mechanically guarantees a tension-free reach, and the ICG biologically guarantees perfusion. That is how you drive a leak rate down to 0.8%.
That biomechanical and technological synergy explains the outcome perfectly. The mechanical precision directly mitigates the biological risks of ischemia at the staple line.
Right.
What about the other broad metrics? Did this precision translate to shorter hospital stays or lower mortality?
Well, length of stay showed a borderline modest improvement for the robotic group over the open group,
Or the days?
averaging 8.9 days versus 9.9 days, right on the edge of significance with a p-value of 0.05.
Okay, so a day less.
Yeah. However, when it came to the hardest endpoints, overall mortality and surgical site infections, or SSIs, there was no statistical difference across any of the operative approaches. Mortality remained remarkably consistent, hovering around 1% for all groups, and SSI rates were uniformly low, between 1.5% and 2%.
Which is actually incredibly reassuring.
It is.
It demonstrates that regardless of whether you open the patient from sternum to pubis or use an 8mm port, the fundamental surgical tenet of achieving rapid source control is being successfully met across the board in these U.S. centers.
Absolutely.
I mean, a 1% mortality for emergent acute diverticulitis is excellent.
It's fantastic work by these trauma centers.
But we both know you don't get all this high-tech precision, 3D vision, and 0.8% leak rates for free.
Right.
There is always a trade-off in surgery.
Always. And there is a significant trade-off here, and that trade-off is time.
Let's hear it.
Operating time was drastically longer for the robotic approach. The average emergent robotic case required 262 minutes. Laparoscopy averaged 207 minutes. Open surgery was the fastest, averaging 182 minutes.
Wait, let's look closer at that. 262 minutes, that is over 4 hours.
Yeah.
The robot is adding 80 minutes, an hour and 20 minutes, compared to simply opening the patient. In a truly unstable, crashing patient presenting with feculent peritonitis, 262 minutes is an absolute eternity.
It's a death sentence.
Exactly. Every single minute under general anesthesia, every minute with ongoing profound sepsis before source control is finalized, takes a massive physiological toll.
Right.
This time, discrepancy aggressively reinforces the reality that robotic surgery, in its current logistical state, is strictly for the hemodynamically stable emergency patient. If a patient is requiring massive transfusion protocols and escalating doses of norepinephrine the moment they hit the trauma bay, you do not have 4 hours. You open.
100%. You do what you have to do to save their life quickly.
But this leads perfectly into the data point that completely shattered my expectations when reading this, the conversion rate.
The conversion to open surgery, yes.
Yes.
If the leak rate was the most impressive clinical outcome, the conversion rate is the most pivotal operative finding in the entire study.
Let's frame this for a second. When a surgeon initiates a case minimally invasively, whether laparoscopic or robotic, but realizes the anatomy is simply too hostile, the inflammatory phlegmon is too dense, or they encounter a bleeding vessel they cannot safely control, they are forced to abandon the minimally invasive approach.
All right.
They have to make a midline incision and convert to an open laparotomy. In the Kerfman study, the laparoscopic group had to convert to open surgery an astonishing 28.7% of the time.
Nearly 1 in 3.
Nearly 1 in 3 laparoscopic cases failed and had to be opened, but the robotic group, they only converted 7.9% of the time.
And the p-value on that difference is 0.0000005.
Wow.
It is wildly significant.
I was trying to think of how to visualize this mechanical discrepancy. It's like this. Using standard straight-stick laparoscopy to dissect a severe, acute diverticular phlegmon is like trying to disarm a complex explosive device using heavy fireplace tongs while peering through a distant peephole.
That's a stressful mental image.
It's exactly what it feels like. You lack the dexterity, you lack the depth perception, and if things get complicated, you have to smash the door down, you convert to open.
Right.
Operating with the robot is the equivalent of putting your own hands directly inside the abdomen, equipped with a magnifying glass and a headlamp, while entirely bypassing the restrictive fulcrum effect of the abdominal wall.
That is a highly accurate biomechanical analogy. The robotic platform fundamentally changes the surgeon's threshold for what is safely operable in a minimally invasive manner.
Because you can just do more.
Exactly. Think about the specific anatomy of an emergent diverticulitis case. The diseased sigmoid colon is frequently plastered solidly to the left pelvic sidewall by dense fibrinous exudate.
It's a mess in there.
A total mess.
Yeah.
The left ureter is dangerously drawn up into the inflammatory mass. The normal anatomical tissue planes we rely on are completely obliterated.
Yeah.
A surgeon utilizing standard laparoscopy, working with 2D vision and rigid instruments that provide minimal articulation, often simply cannot safely identify the ureter or mobilize the colon without risking a catastrophic iatrogenic injury.
So they bail out.
The safe, prudent, and correct surgical decision in that moment is to convert to open.
For sure.
The robotic surgeon, however, utilizing that 3D magnification, the tremor filtration in the articulating wrists, can perform an incredibly meticulous microdissection.
They can tease it out.
Exactly. They can carefully, millimeter by millimeter, tease the ureter away from the inflammatory phlegmon using precise traction and counter-traction that a rigid instrument just cannot replicate. That enhanced mechanical capability is exactly why the conversion rate plummets from 28% down to under 8%.
It makes total sense when you break down the mechanics. But, as with all retrospective database studies, we cannot just accept the outcome blindly.
No, we have to interrogate it.
We have to ruthlessly interrogate the methodology for limitations and bias. And when we were preparing for this deep dive, you pointed out a massive, glaring confounder regarding surgeon volume.
Oh, yeah.
I think this is the absolute elephant in the room that threatens the validity of the robotic superiority argument.
It is a massive confounder, and to the author's credit, they transparently provided the data on surgeon experience to try and contextualize these remarkable results.
What were the numbers?
The surgeons who performed the emergent cases via the traditional open approach averaged 16.2 robotic surgeries per year in their broader general practice.
Okay, so maybe a case a month.
Roughly. Surgeons who performed the emergent cases laparoscopically averaged 27.3 robotic surgeries per year, but the vanguard surgeons, the ones who successfully deployed the robot in these highly acute emergent cases, averaged 63 robotic surgeries per year.
Wow. That is a staggering disparity.
It is.
The robotic group is performing nearly 4 times the volume of robotic surgery in their day-to-day elective practice compared to the group that opts to open.
Precisely. Yeah. And this disparity forces us to ask a critical, unavoidable question.
Is it the archer or the arrow?
Exactly. Are the phenomenal outcomes we just discussed, the 0.8% leak rate, the 7.9% conversion rate, occurring because the robotic hardware itself is inherently superior? Or are the outcomes superior simply because the surgeons utilizing the robot emergently are hyper-specialized, high-volume master operators?
Right, because a surgeon performing 63 robotic colorectal resections annually is an absolute expert.
They've long since surpassed the steep learning curve. They possess immense muscle memory, innate spatial awareness on the console, and highly refined robotic tissue handling skills.
So when we compare the emergent outcomes of that master craftsman to a general acute care surgeon who only touches the console 16 times a year and understandably opts to open a hospital abdomen, we are no longer just comparing the surgical tools.
We are fundamentally comparing the varying skill levels of the operator.
It is profound selection bias.
It is.
But there is another, perhaps even more insidious layer of selection bias hiding in the data due to missing variables in the intuitive database.
Yes, the clinical severity.
Specifically, the absence of granular disease severity metrics. When we assess acute diverticulitis, we universally rely on the Hinchey classification system.
Right.
Just to review, Hinchey served as a localized contained abscess. Hinchey II is a pelvic or distant retroperitoneal abscess. Hinchey III is purulent peritonitis, where the abscess is ruptured and there is frank pus disseminated throughout the abdominal cavity.
And then the worst one.
And Hinchey IV is the most lethal feculent peritonitis, where there is a free perforation of the bowel wall and raw stool is actively contaminating the peritoneum. The problem is, the intuitive analytics database does not capture Hinchey classifications.
It doesn't.
It simply captures the broad ICD-10 diagnosis of diverticulitis, which constitutes a severe, potentially study-altering methodological limitation. Without the specific Hinchey grades, we are statistically blind. We cannot definitively know if the three surgical cohorts were truly comparable in their baseline physiological acuity.
Exactly. We have to ask the obvious question. Are these high-volume, highly experienced robotic surgeons looking at the preoperative CT scans, identifying the profoundly sick Hinchey IV feculent peritonitis patients, and applying excellent surgical judgment by saying, absolutely not, this patient is an extremist, they need an open Hartmann's immediately?
Very likely.
And conversely, are they selectively cherry-picking the physiologically stable, easier Hinchey II or mild Hinchey III cases to take to the robotic room?
It's the smart move.
If the robotic cohort inherently consists of patients who are physiologically more robust with less severe intraperitoneal contamination from the outset, then of course their ICU admission rates are going to be halved, and of course their leak rates are going to be negligible.
Right. The missing Hinchey variable prevents us from declaring the robotic platform definitively, universally superior for all comers. That is an incredibly plausible and frankly probable clinical scenario. Basic, sound surgical judgment dictates that you do not take a hemodynamically labile, actively crashing Hinchey IV patient, place them in a steep Trendelenburg position, head entirely down, insufflate their abdomen with carbon dioxide gas to 15 millimeters of mercury, and then take 4.5 hours to meticulously dock a robot and perform a resection.
It's a recipe for an on-table arrest.
It really is. The high-pressure pneumoperitoneum severely decreases venous return to the heart, the extreme positioning compromises diaphragmatic excursion and ventilation, and the 262-minute time delay to definitive source control is outright lethal.
You open them fast, you aggressively wash out the stool, you resect the necrotic segment, you staple it off, and you sprint to the ICU.
Yes. And the authors of the study are highly transparent about this limitation. They also critically highlight the systemic logistical barriers to U.S. clinical adoption that currently prevent the robot from becoming the universal standard of care in the middle of the night.
Let's run through those systemic barriers, because this is where the academic data collides with the brutal reality of U.S. healthcare logistics.
The real world.
First and foremost, there is the glaring lack of trained operating room staff after hours. It is one thing to perform a complex robotic low anterior resection at 9:00 a.m. on a Tuesday.
You've got your A-team.
You've got your dedicated, hyper-specialized robotics team there. The scrub tech who knows every instrument, the circulating nurse who knows exactly how to troubleshoot the chic cart if it throws an error code.
It's an entirely different, vastly more stressful universe trying to troubleshoot docking the robot at 2 a.m. on a Sunday.
Oh, absolutely. You are likely working with a skeleton night crew who might primarily cover emergency orthopedics or neurosurgery and who haven't touched the heavy, complex Da Vinci sterile drapes or camera cables in 6 months.
The logistics of emergent robotics are formidable and really cannot be overstated. The drastically longer operative times in a true crashing emergency, as we discussed, form a major, often insurmountable barrier.
Right.
But beyond the staff, there is a profound absence of formal institutional protocols governing emergent robotic use. Very few U.S. hospitals possess a codified policy that dictates exactly when, why, and how the highly expensive robotic platform can be deployed off hours.
I mean, is there a backup console immediately available if a robotic arm fails mid-dissection?
Unlikely.
Yeah.
And who is legally and operationally responsible for the highly complex, multi-step sterilization process of the robotic instruments on the night shift, ensuring they're ready for the 7:00 a.m. elective schedule.
That's a huge point.
Until these massive operational pathways are standardized and rigorously practiced, the 5% utilization rate we saw in the study will likely remain stagnant, confined exclusively to high-resource, quaternary care centers equipped with dedicated 24/7 robotic teams.
So, to synthesize the Kerfman paper, The robotic platform, when applied to emergent diverticulitis, is an undeniably powerful precision instrument that, in the hands of high-volume master surgeons, dramatically reduces the need to convert to an open laparotomy and virtually eradicates the catastrophic risk of anastomotic leaks.
Right.
However, this comes at the steep cost of significantly longer operative times and immense logistical strain. The data fundamentally shows us that what the surgeon brings to the table, their advanced tools, their institutional resources, and their high-volume reps, heavily dictates the operative outcome.
It does.
But this is only half the story.
This is where we pivot.
The Kerfman paper is entirely confined to intraoperative variables. But our second source, the Zog paper, shatters that narrow focus. It proves that what the patient brings to the table, their intrinsic biology, their accumulated frailty, and the socioeconomic deprivation of their zip code might be an exponentially bigger predictor of whether they actually survive the surgical insult.
This is the real wake-up call.
We are pivoting sharply from the technical realities of the operating room to the pre-hospital sociobiological realities of the patient. Let's frame the scope of this problem. Emergency general surgery in older adults, those over the age of 65, carries an immense, often underappreciated mortality risk.
The transition you just made is critical to modern surgical practice. As surgeons, we frequently hyper-focus on our anastomotic technique, our choice of linear stapler, or the precise placement of a robotic port.
Right, the mechanics.
But the physiological and sociological baseline of the patient is overwhelmingly the overriding determinant of their ultimate survival. The Zog et al. Paper from the Journal of Trauma and Acute Care Surgery in 2024 is an absolute masterpiece of public health epidemiology rigorously applied to surgical critical care.
Masterpiece is a strong word, but I think it fits.
It really does. Their objective was incredibly ambitious. They sought to map, quantify, and model the interaction between who you are, which they define as geriatric vulnerability, and where you live, which they define as neighborhood vulnerability.
And the methodology they employed to achieve this is staggering in its scale and statistical power.
The data set is massive.
They didn't just look at a few hundred patients at a single institution. They utilized the massive Florida State inpatient database, extracting continuous data from 2016 to 2019, and then picking it back up in 2021.
Right, they skipped 2020.
Yes, they made the highly intelligent, deliberate decision to entirely exclude the year 2020 due to the massive, unprecedented, confounding effects of the COVID-19 pandemic on hospital admission thresholds, resource allocation, and baseline mortality.
Very smart move.
They ultimately analyzed a cohort of N equals 448,968 older adults who presented with AAST-defined emergency general surgery conditions. We are talking about nearly 500,000 surgical patients.
The sheer overwhelming volume of that data allows for incredibly powerful, highly nuanced statistical modeling that smaller studies simply cannot achieve.
Okay, let's break down the definitions.
Let's deeply examine how they define their variables, because this is where the true genius and innovation of the study lie. For the concept of neighborhood vulnerability, they utilize two highly validated, well-established area-level metrics: the Area Deprivation Index, or ADI, and the Social Vulnerability Index, or SVI.
I've seen ADI popping up a lot more in the literature recently.
Yes, and for good reason. The ADI is an incredibly granular metric. It evaluates factors like median income, the prevalence of poverty, educational attainment levels, employment status, and housing quality, right down to the specific census block group level.
It's very specific.
It is. The SVI looks at similar socioeconomic factors, but broadens the scope to include household composition, like the presence of single-parent households or individuals with disabilities, minority status, and housing type, including whether a neighborhood lacks access to reliable public transportation.
So these indices are essentially a hard numerical representation of how impoverished, marginalized, and under-resourced a specific zip code or neighborhood is. It quantifies the struggle of the environment.
Exactly. Puts a number on the struggle.
But the way they tackled geriatric vulnerability is what I found completely revolutionary. They didn't just lazily rely on chronological age.
Because age is just a number.
Exactly. We all know clinically that a 75-year-old who actively runs marathons, takes 0 medications, and has a strong social network is physiologically a completely different organism from a 75-year-old who is bedbound with severe congestive heart failure, poorly controlled diabetes, and chronic kidney disease.
Right. Relying on chronological age alone is a terrible, highly inaccurate proxy for true physiologic reserve.
So what did they use instead?
To solve this, the researchers utilized a Bayesian latent variable model.
Okay, we need to clarify the Bayesian part for the
I
listener.
know, it sounds like stats jargon. But in simple terms, a latent variable is a complex concept that you cannot measure directly with a single test, like true physiological frailty, but you can accurately infer its presence and severity by simultaneously measuring other highly visible variables that act as its symptoms.
Like inferring the wind by watching the trees move?
That's a perfect analogy. Instead of just looking at the date of birth, this Bayesian model synthesized chronological age, multimorbidity, meaning the sheer number and severity of coexisting chronic diseases a patient carries, and the patient's hospital frailty risk score into a single, comprehensive, dynamic metric.
Okay, that makes sense.
They then stratified this comprehensive vulnerability metric into quintiles, ranging from the lowest 20% of vulnerability, the highly robust, to the highest 20%, the profoundly frail.
I love the elegance of that model. It synthesizes the entire complex biological picture of the patient into a functional reality.
It's much more useful clinically.
So let's look at the baseline findings before we even introduce the neighborhood interaction. What is the raw reality when a patient residing in the highest quintile of geriatric vulnerability, the absolute oldest, sickest, most frail 20% of the population, undergoes a major emergency general surgery?
The risk-adjusted data is sobering. It demonstrates that patients falling into that highest quintile of geriatric vulnerability face a staggering 14-fold higher risk of death at 30 days compared to the robust patients in the lowest quintile.
Wait, 14-fold?
Yes, we're talking about a baseline hazard ratio of 14.
A 14-fold massive increase in the baseline risk of death. That alone is a terrifying metric.
It is.
But here is the absolute crux of the paper. This is the multiplicative interaction that completely changes how every surgeon listening needs to view their preoperative assessment. I have to ask the crucial, terrifying question. What happens when you mix a highly frail, highly vulnerable patient with a highly deprived, under-resourced neighborhood?
This is where the numbers get scary.
What happens when that exact patient in the highest quintile of biological geriatric vulnerability happens to reside in a zip code that sits in the highest quintile of the area deprivation index?
This is exactly where the hierarchical survival models reveal a reality that should alarm every practitioner. The researchers took that exact same level of extreme, top quintile geriatric vulnerability and stratified the outcomes purely by the neighborhood the patient lived in.
Okay.
If that highly frail patient lived in the least vulnerable neighborhood, a wealthy, highly resourced, affluent zip code, their hazard ratio for 30-day mortality was 6.32, with a 95% confidence interval ranging from 4.49 to 8.89.
Okay, let's process that. Their profound baseline biological frailty gives them a roughly 6-fold increase in mortality risk, even if they live in a rich, highly supportive area.
Correct. Their biology dictates a 6-fold risk. But if that exact same highly frail patient with the exact same multimorbidities in the exact same age lived in the most vulnerable neighborhood,
Yep.
a highly deprived, impoverished, low ADI zip code, their hazard ratio skyrocketed to 15.1.
It doubles.
It more than doubles, with a tight confidence interval of 12.57 to 18.19. The neighborhood effectively doubled the mortality risk of the underlying biological frailty.
Let me repeat that because it is so vital to understand. The geographic location, the socioeconomic deprivation of the neighborhood itself, more than doubled the 30-day mortality risk for the exact same level of biological frailty. We have to dig into the mechanism here. How does a zip code physically kill a surgical patient?
It is the brutal, tangible biological embodiment of the social determinants of health.
Explain that.
A patient residing in a highly deprived, high ADI neighborhood almost universally lacks access to consistent, high-quality primary care. This means their chronic diseases, their diabetes, their hypertension, their COPD are poorly managed and actively causing end organ damage long before the surgical emergency ever occurs.
So they're already starting from behind.
Way behind. Furthermore, they likely experience a profoundly higher allostatic load. Allostatic load is the cumulative physiological wear and tear on the body caused by chronic, unrelenting stress.
The stress of poverty.
Yes. It is driven by systemic issues like food insecurity, living in food deserts, poor housing conditions, and financial terror. This chronic stress state triggers chronic, low-grade systemic inflammation, which completely depletes their physiologic reserve.
Wow.
So when they are suddenly hit with the massive acute physiological stressor of an emergent laparotomy for a perforated bowel, their body simply has absolutely nothing left in the tank to mount an effective immunological or hemodynamic recovery response.
They just crash.
Exactly. Furthermore, the environment dictates the postoperative survival just as heavily. When they're discharged, they're returning to an environment that is structurally incapable of supporting a complex surgical recovery.
Right.
They may lack reliable electricity or refrigeration for their expensive postoperative antibiotics. They may lack clean running water for crucial daily wound care. They likely lack reliable transportation to make it to follow-up clinic visits.
So a minor issue becomes fatal.
Yes, the neighborhood deprivation guarantees that any minor, otherwise manageable postoperative complication, like a superficial wound infection or mild dehydration, rapidly spirals unchecked into a lethal systemic event.
It is a profound, unforgiving structural failure, and the data gets even more stark, more horrifying, really, when the researchers factored in racial and ethnic minority status. The compounding synergistic effect here is staggering.
It's deeply troubling. The researchers deliberately isolated the data, specifically for racial and ethnic minority patients, to see if the neighborhood effect was amplified.
And was it?
Oh, absolutely. For these minority patients, the hazard ratio associated with the highest geriatric vulnerability jumped from 11.53 in the best, most affluent ADI neighborhoods to an astronomical 40.67 in the worst, most deprived ADI neighborhoods.
40.67.
Yes, and the 95% confidence interval on that 40.67 was incredibly wide, ranging from 22.73 to 72.78, indicating a massive, highly variable but undeniably profound risk.
A 40-fold increase in mortality. I look at this like a toxic multiplier in preoperative risk assessment.
That's exactly what it is.
A minority patient living in a high ADI zip code who is chronologically 70 years old essentially carries the emergency general surgery mortality risk of someone vastly older and infinitely sicker who happens to live in a wealthy, well-resourced zip code.
It completely warps how we see risk.
It does. The historical disparities, the entrenched structural racism, and the chronic generational underinvestment in these specific neighborhoods act as a toxic multiplier on the patient's biological age. We simply cannot look at a 75-year-old minority patient from a deprived, high ADI neighborhood and a 75-year-old white patient from an affluent, low ADI suburb and pretend they carry the same operative risk, even if their preoperative CT scans show the exact same acute diverticular pathology.
Their physiological weathering, the damage their environment has inflicted on their cellular resilience is entirely different.
Exactly.
That is the exact sobering conclusion the authors draw from this massive data set. The intersection between these vulnerabilities fundamentally and irreversibly alters expected outcomes, such that otherwise chronologically or biologically less vulnerable patients become functionally and statistically equivalent to those who are, at baseline, much older and much sicker.
It's sobering. But, as we rigorously did with the Kerfman paper, we must analyze the methodological limitations of the Zog data to ensure we are interpreting it correctly.
Right, let's look at the caveats, because this is epidemiology, not a randomized controlled trial.
Exactly. What are the big ones?
First, we must acknowledge that this is a single-state study. Florida possesses a very unique, highly concentrated, and specifically distributed older demographic.
Lots of retirees.
Yes. The critical question is, does the specific highly lethal interaction between ADI and frailty seen in Florida generalize perfectly to the rural, isolated populations of North Dakota or the dense urban populations of New York City?
Probably not perfectly.
Right. It almost certainly does conceptually, but the exact hazard ratios and the magnitude of the multiplier might differ significantly. Second, the entire study relies on administrative claims data.
Which is always tricky.
Very tricky. The specific ICD-10 codes used to calculate the hospital frailty risk score are entirely dependent on the accuracy, diligence, and training of medical coders, which we know can vary wildly between different hospital systems.
Yeah, garbage in, garbage out. And then there is the statistical concept of the ecologic fallacy, which the authors rightly acknowledge. Break that down for the listener because it's crucial when discussing neighborhood-level data.
The ecologic fallacy is a logical flaw that occurs when you attempt to make definitive inferences about a specific individual based purely on aggregate data collected for a larger group.
Okay.
ADI and SVI are strictly area-level metrics. They assess the average deprivation of an entire census block. The statistical model inherently assumes that the individual surgical patient experiences the exact average level of deprivation of their zip code.
But clinically, we know that isn't always true.
Exactly. A relatively wealthy, highly resourced, well-supported individual could happen to live in an otherwise highly deprived zip code, or conversely, a highly vulnerable, completely isolated individual could be living in a basement apartment in a highly affluent zip code.
The zip code doesn't tell the whole story for one person.
Right, the area level index simply cannot discern the nuanced financial and social reality at the individual person level. However, despite this inherent epidemiological limitation, the macro level trends revealed by 500,000 patients remain incredibly powerful, highly robust, and undeniably statistically significant.
So we have traversed the hyper-focused micro-level technical details of robotic surgery, and we have navigated the macro-level population-based epidemiological data of neighborhood vulnerability. Let's move into the clinical application.
Let's bring it home.
I want to round out this deep dive by extracting practical, immediately actionable implications for the listener's practice. So question 1. Does the robotic data from Kerfman actually change the standard of care today? If I am the attending trauma surgeon on call tonight, and a highly inflamed Hinchy III diverticulitis rolls into my bay at midnight, am I committing malpractice by opting for the traditional open Hartmann's procedure?
Absolutely not. And we can look directly to the citations heavily referenced in the source material for clear, evidence-based guidance here, specifically the 2023 WSES, the World Society of Emergency Surgery, consensus statement on laparoscopic first approaches to general surgery emergencies.
What do they say?
While the robotic data presented by Kerfman is phenomenal, that 0.8% leak rate and the 7.9% conversion rate are undeniably impressive clinical achievements. The logistical reality of a 262-minute operative time, combined with the study's implied requirement for 60-plus cases per year of dedicated robotic experience, means that robotic surgery is not ready to be declared a blanket standard of care for all U.S. hospitals at 2 a.m.
It's just not practical yet.
It's not. It remains a highly specialized tool tailored for high-volume quaternary centers and highly trained master surgeons. The traditional open Hartmann's, or a laparoscopic approach, if the surgeon is highly skilled in operating a hostile environment, absolutely remains the bedrock of safe, rapid, definitive source control in the hemodynamically unstable emergency patient.
So stick to what you know.
Exactly. The immediate clinical takeaway is not to dangerously force the robotic platform into your emergency practice if you aren't comfortably performing 60 cases a year electively. The true takeaway is that as robotic training becomes progressively more deeply embedded in surgical residencies and fellowship programs, we will eventually witness a massive, undeniable paradigm shift in how these emergencies are managed.
That makes perfect sense. Primum non nocere, do no harm. Stick to the tools and techniques you have absolutely mastered when the patient's life is immediately on the line.
For sure.
Okay, let's address the second major clinical question. How does a surgeon actually use the ZOG vulnerability data in the chaotic environment of the trauma bay? This is the most common practical frustration I hear from surgical colleagues when we discuss social determinants of health.
I hear it all the time, too.
We are surgeons. We fix acute structural anatomical problems. We cannot cure a neighborhood's chronic systemic deprivation in the emergency room. We cannot magically change a patient's ADI or reverse their lifetime accumulation of allostatic load while they are hypotensive on the operating table. So what do we actually do with this epidemiological information?
It is a completely valid, highly practical frustration, but it fundamentally misses the core purpose of advanced risk stratification.
How so?
You cannot change their ADI, but understanding this data must immediately and fundamentally alter three critical aspects of your clinical practice: your goals of care discussions, your informed consent process, and your post-operative ICU and discharge triage.
Okay, unpack that.
If you are evaluating an elderly patient in the emergency department who scores high on the Bayesian latent variable model, meaning they are visibly frail, they have significant multimorbidities, and you note from their chart that they live in a high ADI-deprived area, your informed consent discussion with the patient and their family must be radically, immediately different.
You can't just give them the standard spiel.
Exactly. You cannot just casually quote them the generic baseline 1% mortality rate for an open colectomy. You must transparently communicate the harsh reality that their specific, unique combination of profound biological frailty and severe social vulnerability gives them a 15 to 40-fold increased risk of dying within 30 days of the operation.
That is a brutally honest conversation.
It is, but that brutal, honest statistical reality might entirely change the family's ultimate decision regarding pursuing aggressive, heroic surgery versus opting for immediate, compassionate palliative care.
That is a critical practice-altering point. You are no longer just quoting the risk of the surgery. You are quoting the risk of the surgery in that specific patient's body and environment. It changes the entire reality of the prognosis.
Exactly. It individualizes the risk.
Hmm.
And furthermore, if the decision is made to operate and you achieve source control, your postoperative clinical pathways must adapt immediately.
Magic pathways won't work.
Standard routine discharge pathways will absolutely fail these highly vulnerable patients. If you discharge a frail, high ADI patient to a deprived neighborhood on postoperative day 5 with a standard sheet of written instructions and a prescription they can't afford, they will inevitably bounce back to your emergency room in florid sepsis, or they will die quietly at home.
What's the move?
Knowing their extreme vulnerability means you, as the managing surgeon, must initiate aggressive, highly coordinated, multidisciplinary discharge planning on postoperative day 0.
From the minute they hit the ICU.
Yes. You involve social work, physical therapy, and home health nursing immediately upon their arrival in the ICU.
Right.
You ensure they have reliable transportation meticulously arranged for their follow-up clinic visits. You are no longer just managing the integrity of the anastomosis. You are actively managing their profound systemic vulnerability to ensure your operative success isn't undone by their environment.
Which brings us perfectly to our summary conclusion for this deep dive. The future of emergency general surgery, as illuminated by these two pivotal papers, requires a highly sophisticated dual focus.
It really does.
On one hand, we must relentlessly continue to push the boundaries of operative precision, safely adopting highly advanced tools like the robotic platform when logistically safe and clinically appropriate to minimize the iatrogenic physiologic insult of surgery, drive down conversion rates, and fiercely protect our anastomoses.
Yes, the technical side.
But simultaneously, we must recognize the undeniable truth that the most perfect, masterfully sewn, ICG fluoresced, double-stapled robotic anastomosis will still inevitably fail if the patient's systemic biology has been hollowed out and depleted by chronic historical and geographic disparities. A patient's zip code dramatically and irreversibly rewrites their surgical risk profile.
I urge every practitioner listening to look far beyond the immediate acute pathology illuminating the CT scan. Whether you are operating with a state-of-the-art Da Vinci Xi system or performing a rapid, standard midline laparotomy with a scalpel and a self-retaining retractor, accurately factoring in a patient's neighborhood deprivation and their baseline biological frailty is just as critical to their ultimate survival as your operative technique and your choice of suture.
I want to leave you with a final provocative thought to mull over as you head into your next shift or your next morbidity and mortality conference. Imagine the inevitable collision of the realities presented in these two studies.
Oh, this is a tough one to think about.
What happens when the highly frail, highly vulnerable geriatric patient from Zog's study, the minority patient from the high ADI neighborhood carrying the terrifying 40-fold mortality risk multiplier, presents to the emergency room with acute, complicated diverticulitis?
Right.
Because of the deeply entrenched realities of systemic inequalities in healthcare infrastructure, that exact patient is overwhelmingly likely to present to a low-resource urban safety net hospital or an isolated rural facility. A hospital that completely lacks the high-volume, highly specialized robotic surgeons, the 247 dedicated robotic OR teams, and the expensive ICG technology highlighted in the Kerfman study.
It's tragic irony.
It is. As acute care surgeons dedicated to optimizing patient survival, we have to recognize the stark logistical and structural reality we're operating within. We are rapidly approaching a deeply fragmented, two-tiered system of surgical intervention.
We really are.
A structural reality where the specific patients who biologically and sociologically need the absolute highest level of minimally invasive precision, the absolute lowest conversion rates, and the absolute lowest chance of an anastomotic leak just to survive the physiological insult of surgery, are the exact same patients who are geographically and economically the least likely to ever have access to that life-saving technology. The precision is advancing rapidly, but the access is not.
Something we all need to actively work on changing.
Absolutely. Thank you for joining us on this deep dive. Stay sharp, trust your training, and we will see you next time.